Welcome to the webinar Implant Integration, Basic and Advanced Principles. The lecture is being presented by Jean Peterson, MS, CDT, and we are going to begin shortly. And with that, it is my pleasure to introduce Jean Peterson, MS, CDT. He is the Director of Technical Development and Learning at Stern Gold. With over 35 years of experience, Jean has an extensive and diverse background in the dental industry, including R&D, clinical and dental laboratory workflows, production, and management. After owning and operating a full-service dental laboratory for 18 years, he spent almost a decade with the leading digital denture and technology company. A pioneer and subject matter expert in digital dentures, Jean has written and co-authored research and white papers on this and other technical subjects. And with that, I get to say, take it away, Jean.
Thank you, Jessica. You're the world's greatest webinar host. I've been doing this for a long time, since webinars were a thing, and you're a great host. I appreciate it. Thank you for having me. I'm honored to be with you and the group and NDX and have the opportunity to share some thoughts tonight. So tonight we're going to be here for 2 hours, and we're going to take a big journey through implants, talk about a lot of things in general. I would encourage you, if you're interested in implants, to find additional courses that'll drill in deeper into the subjects you need to get confidence and to give you the ability to be a good implantologist and an effective one. So this is we're gonna touch on a few subjects tonight. We're going to talk about basically we're going to talk about integration, implant integration, the role of an implant in the mouth, and we're going to talk about how all these different modalities can bring quality of life to your patient, better quality of life to your patient. We're going to talk about indications and contraindications to implant dentistry, patient selection. It's a big deal. Patient selection is a big deal because we'd like to place implants in everybody if we could, but not everybody is the best candidate. And we'll talk about failures and things like that. We're going to learn about guided surgery. We're going to go through guided surgery since that's something that's very much in the forefront these days. And we're going to finish our conversation this evening talking about implant-related and implant overdentures and the important concepts there. So as Jessica said, I am with Stern Gold. I'm not being paid for this, although I am a full-time employee with Stern Gold, and I've been here for about 5 years and proud to be here and for what I do. It's a lot of fun. I get to be at the tip of the sword in a lot of aspects in dentistry, and it's where I love to be, and hopefully, it'll be where I'm at for a long time now. So let's go ahead and get started. I should have had that slide up sooner, but that just shows where we were. So a dental implant. We know that the dental implant it's also known as the root form. Okay, it's basically the best replacement for a tooth that we know of today. It's a surgical component usually made of surgical grade titanium alloy, grade 4, which is biocompatible with the tissue. We know that there's a lot of talk about zirconia and ceramic implants now, more so in Europe, but those are becoming more and more discussed. I'm not going to talk about those tonight, but we're going to talk about metal alloy titanium implants. It interfaces with the bone and the jaw to support and retain the dental prosthesis, such as abutment or crown, a fixed bridge, or a complete overdenture with attachments. We'll talk about that tonight. And it is state-of-the-art. It's standard of care replacement that mimics a natural tooth, and should be something that everyone, if you're wanting to cross over that threshold and place implants, and that's why I believe why you're here tonight, is to learn if this is an option for you. It's a great tool to have in your armamentarium as a clinician, to be able to offer patients that option or those options. And I just want to say here, there's a lot of discussion as of late about training of implants. I mean, by all means, this is no definite or finite or infinite amount of training you're going to get tonight. It's not definitive. This is an introduction, And there are a lot of great courses out there that will train you to different levels of proficiency and effectiveness as a clinician. And I would encourage you to seek those out because there is a lot of discussion now about implants being placed by clinicians that aren't properly trained. And as this course is supposed to be, this webinar tonight is supposed to be an introduction. There are plenty of courses out there that have live patient, that are continuum based, that have many hours, many hundreds of hours of CE that will completely qualify you to place implants. And I'd encourage you to do that if there's any doubt in your mind, because the leading source of litigation right now in dentistry is errant implant placement. So not to scare you away, you're here to learn about implants, but just to be completely honest with you, and I want to put it all on the table, but it's something we need to be considered with. And one other disclaimer, as Jessica mentioned, I'm not a clinician, I'm a technician. So I've done a lot of research in these subjects throughout my life, and spent a lot of time writing and learning about them. But I'm going to bring some biological principles to bear tonight through my education, but also I'm going to give you a perspective from the technical aspect of doing implants and the idea of prosthetically designing your cases and being aware of things like that. Because in the old days, when I first started doing implants, this has been back in the early 90s, we get an implant from the doctor, from the oral surgeon, that says, okay, I found the bone. Now you make a crown on top of it. You restore this. And so we are left to do what we had to do to make it work. Now we understand that it's not quite that way. We really should prosthetically design every one of our cases. So keep that in mind. That's one of the takeaways I want you to have tonight. All right. What are the components of an implant system? So if you look at a tooth, we mentioned it's a natural replacement for a tooth. We have the crown of the tooth, we've got the gingival interface, we have the gingival margin, and we have the root that's in the bone. The same thing with an implant. We've got a titanium screw that goes into the bone now and anchors an abutment to a crown. So very similar function and mechanically integrated parts to a natural tooth. And we have to make sure that those are designed correctly so they function correctly and they survive. The reason that we're one of the main subjects tonight is to talk about implant integration and success. So I'm going to get to a couple of slides that talk about implant success and how to avoid failure, because one of the jobs that I have working at my company is as a manufacturer, implant manufacturer. We see all the failures come in. When they come in, I mean, we don't have a lot of failures, but if they do come in for whatever reason, a return. So if a doctor drops an implant on the ground, we return it, and we have to file an FDA report on that implant as a failure. Okay, for whatever reason, whether it came out because of infection or it came out because it was touched, by somebody's glove before it went in, they all have to be reported. And so we have to do an investigation on that for regulatory reasons, and we have to dig in to drill into why that implant failed. Most of the time, it has nothing to do with the manufacturing. I would say probably 99.99% of the time, it has nothing to do with the manufacturing. It has to do with either the either clinician error or patient selection. And of those two, I would put patient selection at the number one spot. And we're going to talk a lot about patient selection tonight. So we want to make sure that we maintain that area where that implant is placed in the best way possible to encourage and enhance the opportunity for bone integration into the implant, so it becomes something that the patient can have for a lifetime. Again, just the parts, when you're talking about a crown or an implant restoration, you're going to have an abutment, either a tie base or a custom abutment, more so today, and a screw. The screws, we're not going to talk a lot about tonight, but the screws are very important. That's a topic for another night, another webinar. But the more screws, the more components you have in a system, the more potential you have for some type of failure, because screws, by definition, go in and they might come out if they're not mechanically treated correctly. And what I mean by that is you have a titanium screw going into a titanium implant. If those screws are not torqued correctly to the manufacturer's specifications, you could have a screw loosen. And that's a big problem because things can break if things get loose. Or if you over torque them, something can break after the fact. So think about the screw, and I'll just talk about this for a second. You think about a screw stretching. The threads are designed so as it inserts into the implant to cause loading to that titanium, that piece of titanium, and it actually stretches. And what causes a screw to be tight is that compression back into the threads. So if you imagine if you over torque it past what the manufacturer says that it should be, over time, that's going to fatigue and it could break with the occlusal forces that are introduced to there. So it's very important that the screws are properly inserted, and I'm going to say properly chosen. So as a manufacturer and somebody who actually makes generic parts, I'm very big on manufacturers recommended or OEM screws, because as any company would say, we want you to use the screw that we designed for that implant. And even though many of the screws are very similar in design and thread design and material, if you use the wrong screw, if you try to use a generic screw to save a couple of bucks, chances are it's going to fail, and you really don't want to run that. You really don't want to run that risk. So at our company, we have implants that we make our own screws for, and I would expect if you're replacing an implant from any other company to use those screws that come with the implant. So that's just a word of advice, because I've seen plenty of them fail for reasons that we've just discussed. So anyway, enough about screws, but it's an important topic. All right, the advantages of implants, they function like natural teeth. They prevent bone loss. Remember, and conservatively speaking, you want to maintain something in the bone, because if you think about conservative dentistry, you don't want to cut on a tooth, because what's going to happen? It's going to progressively potentially get worse, which leads to a filling, leads to a crown, leads to a root canal, leads to a fracture, leads to post and core, and eventually that root's going to fail, and then you have an implant. And then what happens? There's nothing in there. If you don't replace that tooth, your bone resorbs. And so you need to keep the bone stimulated. And the best way to do that is to either leave a root in it, keep your tooth, leave the root in, or place an implant in there. And I know several clinicians that if a patient can't afford to do the full treatment plan right up front, what they'll do is they'll actually put the implant in and cover it up, and at least they're preserving the bone, so there's no resorption. Because we have some statistics later on that we're going to share about bone resorption and how bone loss occurs, but it does preserve bone. So it's that natural tooth replacement that's very important. Provides a very aesthetic and natural looking replacement for our restorations. If you look at FP1 restorations in the anterior, and I'll define those if you're not familiar with those terms here in a second, but an FP1 is just a natural tooth. It's going to be like, consider an anterior number 9 central tooth, where you have a gingival colored abutment that's going to not show through ugly in the tissue, and it's going to have a natural emergence profile, and you're going to want to make that look as natural as possible. And you can make those look as natural as regular teeth. With custom abutments and custom temps, you can create emergence profile that look as good as the tooth that came out looked. And that's a beautiful thing on some of these implant cases, if done correctly. And that also helps for keeping them hygienically clean, because the most important part of an implant is the interface between the abutment and the restorative platform. And if that's not connecting perfectly, i.e. the screw and the connection, you're going to get bacteria leakage, and then you're going to get periimplantitis, and you're going to get bone loss, and then you're going to have remodeling around that bone, that implant. Your bone level is going to drop, and you're going to have an exposed implant. And there's a lot of discussion now about smooth collars versus machine collars versus or polished collars versus machine collars versus rough finish collars. because a lot of dentists, a lot of clinicians that I talk to, they anticipate that bone loss because of some type of periimplantitis or some type of just natural bone loss, and they don't want that rough surface of an implant. An etched surface all the way to the restorative platform, if you get some remodeling, you don't want that rough surface exposed, because what's going to happen? It's going to be a harbinger for bacteria. It's going to attract bacteria. It's going to be hard to keep clean. And it'll be a forever challenge to keep that healthy. So maybe the idea of a polished collar is a way to go. But we can talk about that another time too. Anyway, natural aesthetic looking teeth. Implants can last a lifetime if they're maintained. If they one of the ironies of placing an implant and hoping that it lasts a lifetime is the fact that most times, I mean, now we're talking about trauma or genetically missing teeth, but if somebody loses a tooth because of hygiene habits, they're going to have to change their habits, or they're going to lose the implant too. So that's something to consider. If if the reasons that they had gingival disease to begin with, well, that same thing is going to happen with the implant. They must keep it clean. You can preserve the adjacent teeth. No need to prepare adjacent teeth. So the old idea of I made my living owning a lab doing 3-unit bridges. I love 3-unit bridges. Call it 4 units even, because now you can replace one tooth with 3. You're mutilating the 2 adjacent teeth. Always kind of bothered me about that, even though I was glad to do a 3-unit bridge. And I'm sure the clinicians liked it too, because that's a great daily production piece. But what are you doing? You're having to sacrifice 2 teeth to make one to fill that hole. So the implant prevents the need to destroy an adjacent good tooth. And I've just become more conservative over my years, but call me old-fashioned. You can preserve occlusal vertical dimension, OVD. Prevent face sagging. That's a big deal. Again, it's all about keeping that patient naturally looking to restore them quality of life that they once had, the psychologically and functionally. We restore natural diet, biting forces to what they were used to using most of the time. Now, there are some issues about bruxism that become a problem, but if all else being equal, normal situations, they can chew normal things. I've got an implant. My dentist isn't listening, but I crunch ice on it all the time. It's a terrible thing, but whatever. I've had it for almost 20 years. Restore natural diet, or excuse me, denture stabilization for overdentures. We're gonna end out this evening talking about overdentures, and I love overdentures. It's a big part of my life, and talking about dentures and overdenture stabilization. And it's important because in a good way, you can restore a lot of quality of life to the patient, improve speech and function, improve ability to link future restorations. It's retrievable. Now, there are one-piece implants out there that have their advantages, but most of the time we're placing an implant that has an abutment, so it's retrievable and you can repair it if you need to. If that next to it goes, you can always splint 2 together if that's the right situation. There are situations where you'd want to do that and where you wouldn't want to do that. And more than anything, provide a complete treatment plan to your patients. As a clinician, you don't have to send them down the street unless that's something you want to do. All right, so a lot of advantages. Patient selection and indication. So the bone must be sufficient quantity and quality to be strong enough to hold and support an implant. If there's not adequate bone augmentation and or guided bone regeneration may be required. So again, we talked initially about the need for good patient selection. So that bone base, that bone that we're placing the implant in has to be of sufficient quality and quantity. If not, remember I talked about all those implants coming back? So the failures that I see from returns from quote unquote loose unintegrated implants. One of the things that we solicit from the clinician is what's called an MDR, medical device record, and it's basically a questionnaire that asks about the patient's health history, what medications they're on, any type of extenuating circumstances that may be around why that implant could have failed. We talk about what the initial torque value was, what the quality and quality of the bone was. Did they use a CBCT? And most of the time, I would say the vast majority of the time, it has to do with insufficient bone, inappropriate placement of an implant, or non site regeneration, okay, or lack thereof, which should be done. That's very important. And a lot of times it's not done. And so they stick the implant in, they put a graft around it, and they expect it to heal. And you can't do that. You just can't expect an implant to have a chance if you're not, if you don't give it the best chance for survival, and that is good bone. Or place, do the site regeneration, graft it, let it heal, and then put the implant in. That's the responsible thing to do. One of the questions might come up about, do I immediately load my implant or do I let it heal? I can tell you from my experience doing lots and lots of implant courses with very, very skilled and experienced clinicians, the majority of them, notwithstanding the ones that do like the All-in-4 and the tooth in a day treatments plans, but regular implant dentists that are placing single implants, and even those who do full mouth rehab, they're letting implants heal. Okay, they're doing the site regeneration. They're doing the best they can to preserve the bone or regenerate the bone, and then they place their implants, or excuse me, then they restore them. So they let them heal. They place the implants, let them heal, and then they restore them. So from my experience as a non-clinician, observing these other clinicians, it seems like I would say a majority of them let their implants heal, which is good. Which is good practice in my opinion. Overall, let's see, the natural teeth and supporting tissues near where the implant will be placed must be in good health. Again, we talked about, are they going to learn how to take care of their teeth now if they have an implant, if they didn't before? Well, that's something as a clinician you have to deal with your patient. Patient's overall health history and current comorbid conditions and medications must be considered. That should not interfere with the integration of the implant. We're going to have a list of things here in a second to talk about ways to interfere with implant healing and osseointegration and fibrous integration. There are a lot of ways to fail your implant potential. Okay, and most of it again has to do with the patient. If you don't take those things into consideration. Occlusal forces can also be your enemy. What are the opposing? What's the opposing? Is it opposing a denture? Is it opposing natural teeth? Is it opposing a zirconia bridge? Any of those things could affect it. It could cause parafunction and some type of avoidance syndrome, which creates different occlusal patterns, which creates more weird lateral forces or some type of failure. But that all needs to be assessed up front. Again, we're planning this surgery. We're not just doing it. Careful consideration to the prosthetic design is so, so important. As I can say as a technician, I've seen more cases fail because of that than any other reason. And from my experience doing investigations as a manufacturer. Dental implants can be indicated for most edentulous areas. That's one of the advantages of implants. It's a solution where we can save the day most of the time, where the patients cannot tolerate a complete denture, perhaps due to severe atrophic or compromised bone or muscle coordinate or tissue or coordination. Single tooth loss to avoid involving neighboring teeth or abutments. Unfavorable number or location of potential abutments. You're trying to put too much in one space. Low tolerance of mucosal tissue or periodontal disease. So that's another reason why you may want to recommend an implant or not. Parafunctional habits leading to recurring soreness or instability of the prosthetic. This refers to a denture or partial. If the patient gags a lot and they can't tolerate a removable prosthetic, maybe the implant's the way to go. Psychologically, they're unable to wear a removable prosthetic. We're going to talk about that too at the end of the presentation tonight, about how psychologically affected some patients are when they have to go to a denture. and why they would want an implant. Deformities, trauma, or congenital absence. Some disadvantages are also there. Obviously, the treatment plan. A lot of times I hear, well, they couldn't afford to do that treatment plan, so I had to do plan B or plan C. Okay. And as a clinician, you're trying to provide them the best opportunity to have the best quality of life or best restoration possible under their circumstances. So, cost is a big deal. You may want to do all these great treatment plans, but sometimes the patient may not be able to do that. The patient may be reluctant to the surgery. They may think that some implant treatment plans are too invasive. I got to admit, some are very, very uninvasive. They're very atraumatic, and they can be. I can tell you another. When I got my implant, I would have probably rather had a filling than I had when I had my implant because it was that atraumatic. It was single site, anesthetize, go through the tissue to put the implant in. Implant took about 6 minutes to put in. I'm done. No big deal. But to some patients, that might be a big problem. Or you could have more advanced, more invasive procedures. You don't get the immediate results, and that's a good thing. Sometimes if we let our implants heal, then yeah, we get to wait. Okay, so as a clinician and a patient, we get to learn how to be patient, but that's good. Patience is a good thing with implant dentistry. They're worried about the complications. We're going to talk about numbers of failures here in a little bit. As a clinician, you're just going to have to face the fact that a certain percentage of your implants will fail no matter what you do. And that's a national number, and that's a per practitioner, per clinician number. And the obvious, potential of implant failure for whatever reason, that might be a disadvantage. So what are some of the things that we have to look out for when we're selecting a patient? Acute illness, lowered immune system. You have situations that prevent healing, diabetes, prone to infection, slow to heal. Controlled conditions are fine, controlled high blood pressure, controlled diabetes. Always understand, when you're doing your questionnaire, your health history on the patient, that they're honest, and you drill into it a little bit. If they don't know what their A1C is, they're probably, are they really serious about this? If they know what medications they're on for their heart blood, their blood pressure, they probably are going to be controlling these things as best they can. So that's a good thing. So diabetes in and of itself isn't bad. If it's controlled, it's fine. They'll be able to heal. High cholesterol medications, if they have triglyceride problems, again, lowered immune system, it affects the bone mineral density. You've got medically compromised patients in all these areas that you have to consider, how, are the pluses or the negatives, do the negatives outweigh the positives? Bisphosphonate drugs, be it patients that are on drugs for osteoporosis, Fosamax, the other one, Actonel, I think it's called. This really messes with the osteoclastic action of bone resorption, so it can't heal. Part of the healing process in forming or creating osteointegration is that breaking down of bone to allow new bone to come back out, so it can grow. So those osteoporosis related drugs are very harmful and preventative for good implant healing. Anticoagulants, if they're the Xareltos, the Eliquises, those are irreversible, to the healing process. Again, consider that as a negative. It's a not to. And these are things that I see that patients are on when I get an implant return. Well, the implant failed due to mobility, or it failed due to infection. I ask if the clinicians are being forthright with me. I got a whole list of all these medications, and I ask them, were they on these things? And I say, well, there's a very high probability that due to these medications, the implant never had a chance. And if they angiogenic drugs, if they have cancer, that inhibits and prevents vascular growth. So again, we're inhibiting healing. Tobacco use, that's a mixed bag. So tobacco use, 50% of the reduction of oxygen is supplied to the bone at that point when, the nicotine. It's a problem. Now, I've seen plenty of cases where I know smokers who have had successful implants, and it's not the end of the world for every smoker, but for some patients, when other things are involved, when you have other compromised situations, comorbid situations, the smoking could be a very big problem. Because you have the peri-implantitis that is associated with the smoking, and you get bone resorption. So smoking is a big no-no. Maybe you have them stop smoking for a short period of time. I've heard clinicians do that it's very possible to have the patient, suspend their smoking for 6-8 months while the implant heals. Yeah, great. Once it heals, it heals. So consider that. History of bruxism, we'll talk about that. And there are a couple here that are interesting. So lack of operator experience. Remember, initially I opened up this talking about training and being inadequately trained. I am fully. We partner with some very good continuum groups. My organization, I personally do, that put clinicians through residency style training programs, 300 credit unit training programs. It takes a whole year and 8 or 9 weekends and live patient mentored placement, where they learn everything from A to Z on how to place implants. And do I think that's necessary? I would recommend it, because the lack of operator experience could get yourself into trouble pretty quick. Whether it's drill speed, whether it's inappropriate planning on the placement. There are a whole handful of things that could cause failure of the implant based on lack of experience. Okay. Now you got to start at some point. You got to learn, but just again, I want to make sure that that I'm making it clear that be properly trained. Okay. And as professionals and clinicians, you all know what that means to yourselves. I mean, everybody's got a different level of skill when it comes to those types of procedures, and trust me, I've seen super clinicians do a great job, and I've seen others fail horribly. And just make sure you get properly trained. That's all I'm saying. Patient hypersensitivity to the specific components of the implant. There are some cases of titanium allergies, but not a lot. All right, so I'm going to go backwards here. So if you haven't seen this book, I would recommend getting it. And if you're looking at getting into implant dentistry, you're going to eventually get this book or something similar to it. There are a few new books out there that are very good. This by Carl Misch is, he's the kind of the godfather, the recent godfather of implants. I have read through this book probably 3 times in my career as a technician to understand implants and the restorative aspect of it. But I'm going to talk a lot about Dr. Misch and what his philosophy is, because everybody else does. Okay, because he's kind of set the standard in here as far as what what should and shouldn't be done when placing implants. So I'd recommend that you get this and have a copy of it. Go back to this slide here if I can. There we go. So Dr. Carl Misch developed the treatment plan sequence to decrease the risk of biomechanical overload or failure, consisting of the following components: prosthetic design, which we've talked about, patient force factors, key implant position and number, available bone in the edentulous sites, bone density in edentulous sites, and implant size and implants design. So we're going to talk about these really quick. So here's the book again. So according to the stress treatment theorem that Dr. Misch set out in his book, the final restoration is planned, similar to an architect, building a building. Like I mentioned, when I started in this industry, we were getting an implant in the lab, and the doctor said, "Okay, I placed this implant, successful, yay! Now restore it." It was where it was. I mean, we had to do the best we could to restore it and restore it in a way that was responsible. And we didn't really know what we were doing back then. I mean, Dr. Misch was just getting started with this and writing his books, and as were other authors and clinicians, and we just had to do the best we could. We didn't understand all the factors that prosthetically that could interfere with an implant, but now we do, and we know that we need to design it the other way around. Okay, designed with the final result in mind, biologically and functional. The time savings, it's more predictable, better case acceptance, patient satisfaction. You plan your restoration and the abutment, evaluate best directed occlusal forces, and the least probability of failure is your best friend. So at that point, if you're doing your due diligence and prosthetically design your cases, you're going to be a lot better off. And this just shows what we did in the past. We went from implant position to the restoration. Now we understand that we go from the prosthetically speaking, the restoration to the implant. And now you're going to say, well, yeah, the bone is where it is. That's true. But everything in dentistry is a compromise, and we have to make the best choice for the patient in that situation. So put yourself in the best situation by prosthetically designing this where the implant will best survive underneath that restoration. And yeah, there's going to be give and take. As a technician designing these cases, I would always call my clinicians and say, hey, I don't have quite enough room here. I don't have this, or I can't do that. What do you recommend as a clinician? Because ultimately you're driving this case, and you got to make sure that we make appropriate decisions for the best, for the best possible outcome. We talked about the prosthetic classifications. We need to understand these because we talk about these all the time. What an FP1, 2 or 3 is, what an RP4 and 5 is. Basically, an FP1 is an implant restoration that mimics a natural tooth. Okay, and like the number 9, I think the single central anterior tooth looks very natural, has good emergence profile, has nice gingival rolls. It looks beautiful. You can't even tell it's an implant. Okay, that's an FP1. And that can be multiple teeth. It can be a bridge. Number 2, as FP2 is a fixed prosthesis, replaces a crown and a portion of the root tip. Crown contours appear normal, and the occlusal half butt as elongated or hyper-contoured at the gingival. So these are kind of looking like you see in the image over here, what you see with, you get kind of those elongated roots that are going to the fixture level. And, these are not so much as popular as they used to be, because now we're using multi-unit abutments and bringing the tissue up through the transgingival width of the tissue, and we're restoring at the above the tissue level. So when we're going straight to fixture, which there are a lot of old school clinicians who love to still go straight to fixture, a lot of times you're going to face these types of situations. FP3, fixed prosthesis, replacing missing crowns or gingival color and a proportion of the edentulous site. So now we're coloring with pink. This is your typical hybrid that you see, the all-on-4, the all-on-X. And prosthetics or prosthesis is most often used, uses denture teeth or aquilic gingiva. But, we're using more zirconia now, and porcelain fused metal. Well, porcelain fused metal, not so much. Porcelain fused zirconia and titanium frameworks with crowns cemented onto the titanium frameworks as single units. That's becoming very popular right now. Because why? Because if something breaks, you don't have to replace the whole thing. You don't have to take it out and try to and have this huge lab bill. Now I can just, if one crown breaks on a single abutment, then I can just replace that one crown. It's a beautiful thing. RP4s, now you have removable prosthetics, overdentures supported by a bar. There's my bar. Yeah, I love bars. Bars are really great. They're very sexy. They're cool because they're very stable, cross-arch stabilized restorations. Now we don't have to worry about the implants. The implants are mutually protected. I love bars, but we need lots of room. Okay, we'll talk about room. And then you have the RP5s, which are removable prostheses like overdentures, snap-on overdentures, which are not supported by the implants. They're implant-retained, supported by the tissue. Something to remember, because that's very important. If you try to do an overdenture, do a locator case, and you expect those implants to support that restoration, you're going to be really disappointed when those implants fail because you put all those occlusal forces on the implants instead of the denture. And we're going to talk about that because these are implant-retained, not supported, the overdentures. All right. So just keep those in mind. Those are something you need to remember when you're designing your case. So patient stress factors related to the patient, parafunction, bruxism, clinching, tongue thrust, those are things that could affect an implant. Negatively, crown height, restorative space, those lateral forces that are putting strange energy movement or moments onto the implant that cause movement or stress to the connection or the implant in the bone. the masticatory dynamics, and the nature of the opposing teeth all could cause stress factors to the implant assembly. These forces are most damaging to the implant. Bruxism primarily concerns their horizontal or non-functional grinding of teeth present with wear facets on the teeth. So I'm a clincher, I'm a grinder, and I told my doctor to take it out of occlusion. He agreed, and it's been out of occlusion and it hasn't super erupted. I've had it in my mouth for about 15 years. There is a chance the teeth could super erupt if they're not in occlusion, but again, each situation again is a compromise. And in my situation, I needed to have that both for clenching and grinding. I had to have that removed from any lateral excursions or protrusive. Clenching, a habit that generates the constant force exerted from one occlusal surface to another without any lateral movement. Don't present wear facets, but cause fatigue fractures in the implants. Okay, then you have tongue thrusters. Okay, that's a problem in and of itself. So parafunction is a problem with implants. We have to consider that. What is the treatment? Treatment plan is modified primarily in two ways. When the implants are inserted in posterior regions, one, additional implants are wider in diameter because you're distributing those forces. And the anterior teeth may be modified to recreate the proper incisal guidance to avoid posterior interferences during excursion. So you're kind of protecting those teeth. So there is a way around it if it's prosthetically designed correctly. If you have a clencher, what do? Additional implants are indicated with greater diameter. A more narrower occlusal table is recommended, and mutually protected occlusion is indicated as well. So there are a lot of situations, a lot of different implant sizes that favor these types of situations. At the end of the day, we want the most surface area to touch bone, okay? And we like long implants too, because you're going to learn here in a second that torsion and lateral forces affect shorter implants greater than they do longer implants, because those forces are distributed better on longer implants than they would a short implant. But there are indications for short implants, don't get me wrong. Restorative space and the crown height, very important. And we're going to talk a lot about space when we talk about the overdentures. And as a ceramist and a denture technician on my gravestone, I'm going to have, when I die, it's going to say, I needed more room, okay? And that is in all love to my clinician friends. Even though we can't have room sometimes, we need more room. And so, especially in this world, in implants, and especially in overdentures, we must prosthetically design our cases with the room available to put the best prosthetic solution in the mouth, okay? And based on those numbers, that limited space available is going to dictate what we can do. I mean, you could open them up vertically to get more space, yeah. You could, if you've stabilized the jaw and you've actually done it occlusally, correctly, you can open up the vertical, the patient can tolerate it, reprogram them, so to speak. Or you can artificially alveoplast the bone away. Okay, you can take it away. You can do serial reductions on the jawbone, which is somewhat controversial. Some people like to do that, some don't. That's the all-on-4 technique. Chop off the bone. I need 18 millimeters. I'm going to chop off and take my incisal edge and go up to 18 millimeters or 16 millimeters, and I'm going to draw a line, and that's where I'm going to cut the bone. Okay, voila, I have the space. Okay, well, in a lot of situations, and in conservative dentistry, you don't always have the space you need. So use the space that you have wisely. It is measured from the crest of the bone, and it's important that we're measuring from the crest and not like the vestibule, that we're all on the same page from the lab communication to the clinician. It's measured from the crest of the bone to the plane of occlusion, or the incisal edge in the posterior region or incisal edge of the arch in question. Ideal restorative space for mixed implants is about 8 to 12 millimeters. Removable prosthesis often requires up to 12 millimeters, 15 to 20. And like I told you, I'm going to give you a really good graphic on this, because we need room for the parts. We need room for the material. Excessive crown height, on the other hand, can cause too much stress accumulation, leading to crestal bone loss. Because remember, we like longer implants because it distributes those forces into the bone better. Well, you're still going to get, your fulcrum is at the junction. of the implant and the crown. So you're going to get movement there, which is going to cause osteoclastic activity and bone loss. Okay, it's going to resorb the bone at that micro area of the implant system. So very important that we prevent that from happening. And here's a little graphic. This is from Dr. Cooper. His very famous image that shows where are we measuring from? We're measuring from the crest to the incisal edge. Okay, those are the numbers we're talking now. Because in the old days, we used to measure from mucosal, the mucosa or the buccal fold. But no, the numbers I'm going to give you are from the from the occlusal surface, the apex of the ridge, to the incisal edge. When you're talking about bars, we're going to need a lot more space. So just to give you an idea of what you need, this image is from Dr. Charles Goodacre, one of my mentors. You need room for the implant, you need room for the bar, you need space underneath the bar to clean, then you need room for the acrylic. And easily, generally speaking, when you're talking bars, as much as I like them and the options you have, you're going to need 15 to 20 millimeters of space, a lot of space required, but you can do some really beautiful restorations. And this is kind of along the lines of all-on-4 room. But when it comes to overdentures and bars, a lot of the time, these patients are already resorbed, and you're going to have that space naturally, which is a big difference than chopping off bone and taking out teeth just to place more teeth, more implants. And therein lies some of the controversy that's happening nowadays in the legal system, that they're taking out too many teeth for no good reason. Or I guess I should say unethical reasons. Okay, so here's what I promised you. So, whoops, too fast there. So here's a great graphic that shows, I'm going to reintroduce this when we talk about overdentures. Generally speaking, you're looking at, single implant crowns, 8 to 12, bars, 15 to 20, okay? And that's a big range, okay? Now let's talk about lateral forces. So the loads on an implant are very important. How you occlusally set up and prosthetically design this case, or once it's restored, how you put it into occlusion. So one of the things that I'm amazed at, and it's very important, and I want to please take this seriously, is that if you're going to consider doing implants, please review how well you remember dentistry and occlusion, okay? Because occlusion is so fundamentally important. Not only from a restorative aspect, can you prosthetically design, understanding denture technology better, you're going to understand occlusion better to better direct the forces where they need to be in the mouth, okay, so you don't cause problems, okay? So I take that with all sincerity. One of our most popular classes that we teach is a Dentures 101 course, because if I'm in a course with 25 doctors and some of them are out of school less than 5 years, and I say, and they're there to learn implants. They're there to learn. They're there to do an 8-month course on implant dentistry, and they want to do all-on-4s, and we do all kinds of stuff. First thing I say to them, what do you know about dentures? How much do you like dentures? And I just get, deer in the headlight look. What? Dentures? Oh yeah, I did one, or I did some, or I hate dentures. I send them down the road. Please do yourself a favor and reconsider how important denture dentistry is, okay? Denture technology is. And get a refresher course on occlusion, so you can understand not only the prosthetic design aspect of an implant case, especially when you're talking full mouth reconstruction. From my experience, I think it'd be malpractice not to do so, but there are people who think they can do that. Definitely consider your knowledge base and what you remember about dentures. If you do a lot of dentures, you're set. Good job. I love dentures. That's my wheelhouse. Okay. But please go back and brush up on your denture techniques, okay, and your denture principles. All right. One of my soapboxes, I apologize. But we need to understand the different moments of energy, okay, the different loads that are introduced to an implant, and they tend to introduce rotation on three different planes, as you see here. You see a vertical, facial, and you have buccolingual aspects to these stresses. You have clockwise and counterclockwise rotations. You have up to 6 different multiple forces going on at any given time. And they can all cause pathology to that integrated implant. Because once you place that implant, you've had successful integration and you've begun the process, you don't want to mess that up. You don't want to interrupt that, because once you disturb the integration process, and there is a cascade effect here that we're going to talk about, the implant can be doomed forever. It will never heal, whether it's in the preparation of the osteotomy or it is some damage you've done to it through early loading or unduly prosthetically designing the case. Okay, introducing these pathologic stresses to the implant is a problem. Okay, and it will result in failure. Because the restorative space in the crown height is a considerable force magnifier. So you imagine we have distance here, we have length, and everything we do up here is magnifying down here. So it's a force magnifier. Various methods are adopted to decrease that stress. So these are ways that we can decrease the stress according to Mish. So we can shorten the cantilevers, if there are cantilevers, and we'll talk about that a little bit. Minimize offset loads to the buccolingual, reducing the occlusal plane a little bit. Or like we did with me, take it out of occlusion. Increase the number of implants, distribute that force among different, mutually support your implants, if that's an option. Increase the diameter of the implants, fabricate removable restorations that are less retentive and incorporate soft tissue support, i.e. an overdenture. Okay, let the tissue take the load, the soft tissue. For greater than 15 millimeters of restorative space, eliminate all occlusal contacts and centric relation in most posterior parts. That's me. Average recommended AP spread is 15 to 20 millimeters, not exceeding 1.5x for a cantilever. And I'll show you what that means right here. So when you're talking about AP spread, to distribute all the forces evenly among these implants, not only are we worried about doing that, but we're also worried about preventing too much cantilever back here. Remember, Mish said he didn't like cantilevers at all, but we know how much cantilever is allowed now. That's why when you do hybrids, when you see hybrids, you only see one molar, or maybe one bicuspid and one molar, depending on how much space is, depending on how much space you have from the anterior-most implant to the posterior, and you add another half to that, you may have room for, you're probably not often going to have room for 2 molars and 2 premolars, but a lot of time it ends up being just one molar extending back here on the cantilever, as you see right here, because you don't want to put too much stress on those implants. All right, if you put too much stress, caused by too much occlusal force, you will kill these implants. Okay, so AP spread is very, very important. Mish has 4 guidelines to key implant position. Cantilevers should not be reduced or preferably eliminated from the prosthesis. Terminal abutments act as key positions. 3 adjacent ponics should not be designed. Canine and molar sites are key positions when adjacent teeth are missing. Arch dynamics, where he divided each arch, or where the doctor divided each arch into 5 segments. We'll talk about segmenting next. The distance of an implant from the adjacent tooth is 1.5 millimeters, and adjacent implant is 3 millimeters, 2 millimeters on buccolingual apical plates. So what does that mean, the cantilevers? So cantilevers in the prosthesis acts as a force magnifier all the time, okay? Ideal treatment plan should eliminate, when we can, where adequate bone height is not available, the posterior mandible, we give cantilever ponics, yes. Cantilevers act as class 1 levers. That just means that it's a multiplier force on the from where it pivots. And we do not place 3 adjacent ponics together because it creates too much flex. So there are certain situations where ponics and cantilevers are indicated, but we have to understand and consider those. And the key arch positions for mutual stabilization is very important. So it says when multiple missing teeth are extended beyond one of the open paragon segment or pentagon segments, a key implant position needs to be situated in each segment. So what Dr. Mishes is saying, you need to mutually support your implants when possible. So for example, when the central and lateral incisors represent one segment, each of the canines now represent another segment. The posterior premolars and molars are another segment. So each segment is essentially a straight line, okay, as you see in the picture here. And they act to protect one another with little resistance of lateral force. And, the key here is mutual supported implants. Okay, occlusal forces of the opposing arch. So the highest forces are created by the implant prosthesis because the proprioception is lost. Because so you really don't know where, even though there's fibrotic connection now to the implant, once it's completely integrated, you still don't have proprioception. So you don't know how hard you're biting. And that's a problem. So you need to help the patient out by preventing that, by designing it out of their possibility, okay? When the opposing arch has a fixed implant prosthesis or natural teeth, the length of the cantilever should be reduced and the number of implants should be increased. When the opposing arch has a removable denture or the bite force is minimum. And the best friend to implants, I think, are acrylic dentures, okay, because it's very soft and it's forgiving. How are those forces distributed in the mouth? Well, we understand that the maxilla is a force distribution unit, okay? So pressure goes up and it's distributed throughout the skull in the maxilla, where the mandible is the force absorber. So it's going to absorb those forces. There is an adequate, indisputable influence on bone density and clinical success. Dr. Wolf in 1980 or 1892 told that every change in form and function of bone is followed by certain indefinite changes to the internal architecture and equally definite alteration in external conformation in accordance with the mathematical laws. This was his quote. Bone density decreases in jaws after tooth loss and due to less loading. So we talked about having that implant or having something in the bone to keep the bone stimulated. Bone density changes are greatest after the tooth loss in the posterior maxilla and the least in the anterior mandible. So that's why when we're placing anterior implants for overdentures in the mandible, that bone is it's usually very, very dense. It's very avascular, very hard bone, type 1. So understanding the bone quality is very important in your patient selection. I would recommend having a CBCT on every patient. If you can't, find a way to get it because we know that bone, because of natural resorption patterns, that the maxilla generally becomes more narrow and resorbs in, and the mandible, as it resorbs, it becomes wider, and you get these large atrophic mandibles a lot of time, and you have to go cross occlusion. You have to put them in cross function or reverse occlusion to even allow them to work, because the planes of occlusion, the pound lines are so far off when you're doing your model analysis. So and also you can change classification anterior posteriorly. Then the maxilla resorbs posteriorly and the mandible resorbs anterior. So you get these. That's why you get the protrusive class 3 with severely resorbed mandibles. So again, bone quality is very, very important, and we need to understand where we're placing implants and why it's a good position. So always use, if you can. I mean, in the old days, we used to. I mean, I remember a doctor would send me a model, and he'd say, "Design me an implant jig." In this case, with a stone model. I had no idea what quality the bone was, where the bone was, how thick the gingiva was, where undercuts were. I had no idea. I had no X-ray vision to see inside that model. But guess what we were doing? We were doing it that way. They were bone sanding with calipers. They were telling, okay, well, 6 millimeters down, I've got 10 millimeters, and then it goes to 8, and I've got 6 again. It was really, it was very perilous. Okay. And the doctor, put a lot of confidence in me, but what do I know? I'm just creating a jig with a drill on a stone model, it's not very good. Nowadays, we've got really, really nice panel x-rays. We can at least get an idea of what the quality of the bone is. But even better now, we've got such good CBCT data coming in scan quality that we can actually see where the bone is, what the quality is, in Hounsfield units. We know, what the T-score is for a bone and exactly where we're going to place the implant. We plan the surgery and we can plan around poor bone if we're not going to go in and try to regenerate it. So it's a beautiful thing, CBCT, and not only from a liability standpoint should you have it for every case, it's the best planning tool because now in 3D we can slice through that bone and we can see exactly where the right place to put that implant is based on the prosthetic needs of the case. So I would recommend that you never do an implant case without a CBCT. Because as somebody who designs cases, in software, implant cases, it really is, it makes life easier. And I saw the latest, some of the latest technology at the AID show last weekend in Atlanta, and I tell you the quality and the bells and whistles in a CBCT and these softwares are getting so. The word that comes to my mind is just cool. It's so exhilarating to be able to plan a case with so much information. Okay, and it's really fun. Okay, but not fun. But not only fun. It's informative. Okay, and it's responsible. So what are we talking about? We're talking about what do we see when we look at a CBCT? We look in most of the CBCT programs out there are going to give you Hounsfield units, which is a unit that gives density. You can also ask for a DXA test, which is a T-score, which is used for general osteoporosis testing now. But now they've got actual rainbow colored graphic that you can see both in 3D in the slices and looking at large on the flat panel / CBCT now exactly where the good bone and the bad bone is based on color scales. So you know exactly where you're placing it. But either way, understand where the bone is, what kind of bone you're placing, and what kind of bone are we talking about. Bone has forever been compared to wood. Okay, as far as comparing it, you got D1, D2, D3, D4 bone. And they've always, in the mandible, anterior mandible, where it's very avascular, interforaminally, there's hardly any blood supply there. And it's just rock solid cortical type bone. It's hard, it's very dense, type 1 bone. And they compare that to maple. Then as you move back in the mandible and also in the maxillary, the anterior maxilla, the premaxilla area, you've got D2 bone. This is a more cancellous bone, trabecular bone, where you've got a nice defined cortical plate all the way around surrounding your bone, the trabecular bone, and lots of blood supply, good, healthy bone. From what I understand and from what I've experienced working on cadavers, type 2 bone is kind of your whole shot. That's where you like to really be. If you can find type 2 bone, you place implants there all day. Okay. Type 3 bone gets a little bit softer. So the type 2 is going to be considered white or pine wood. Then you have type 3, which is more balsa woodish, kind of make balsa wood airplanes. And then you have type 4, which is you want to run from that's styrofoam. Okay, that's type 4, generally in the posterior maxilla tuberosity area. But the good news is that can be regenerated. We can fix that. We can do a sinus lift if it's low in height, vertical height. We can put a bone graft in and let it heal. And we can do different things to put better bone in the posterior area in the maxilla and have success. Don't just throw it in the cruddy bone and expect it to heal. You're going to experience a lot of heartache there. So the type 1, 2, and 3 bones, you're going to get more primary stability. You're going to be able to load immediately. Remember we talked about, do I load? Do I not load immediately? Well, if you get primary stability, you're getting 55 Newton centimeters. Maybe you can load it. Okay, maybe it's fine, because at some point when you get to about 35 to 55 Newton centimeters, that implant's as tight as it's going to be because the bone contracts around that implant. So in the literature, it says that, yeah, it's okay to to load the bone. It's primarily stable enough to load. But like I said, a lot of clinicians like to let them heal anyway to give that implant the best chance to integrate. Because what are we doing if we immediately load a crown? Well, first, it's just been placed in the bone. Now we're going to create occlusal forces on it. And a lot of times, granted, they'll take them out of occlusion, but you still run the risk of creating some occlusal issues if you immediately load that crown incorrectly or that implant incorrectly. Other things that affect, they're affected by the bone quality or healing time, the drill speeds. The drill speeds are really important that we'll talk about here in a second because you can damage the bone based on how much you heat it up. It's very critical that we understand. One more thing I want to share on this graphic is over here it shows, and you can get this graphic. This is out of Mitch's book here. You get the Hounsfield unit. So when you're looking at a CBCT, generally speaking, if you have the type 1 bone, you're at about 1250. And you'll be able to move your mouse around and it'll pinpoint areas and it'll give you an average of that area. Okay. It'll tell you, okay, you're 1200 Hounsfield units, or you're at 850 to 1200, or you're 350 to 850 for type 3 bone, or 150 to 350 on type 4 bone. But if you look at a map of the jaws, you got the maxilla, you got type 2, type 3 in the premaxillary area. As you move back, you get softer. And then when you have type 1 in the anterior mandible and type 2, moving back D3, D2 in the back. So depending on what density your bone is could determine what type of implant or how aggressive of an implant you're placing into the bone, because we have to consider the thread design, because some implants are considered more aggressive for less dense bone. So for example, there are specific implants that are designed for type 3 bone that have very big wing threads, okay, that grab and bite a lot of bone, and that's great. That's what they're for. And you have other implants that are specifically designed with nice, tight, fine threads that are for more dense bone. And we're not going to go into all those details tonight, but again, that's a conversation for another course. But there are situations where implants can work in most of these situations. Okay. Implant success. We've been leading up to this statement. What does that mean, implant success? So dental implants, the success of implants is related to, as we mentioned, the clinician's skill, the patient's health, patient selection, the quality and quantity of the bone, and continued patient hygiene. So it doesn't end with, okay, we got the implant in, it's healed, it's good. You got to continually maintain this bone. I mean, if you're not giving a water pick to your implant patients when they get their case, think twice about that. I mean, I water pick mine every night, and that's what my clinician told me to do, and that's what I've heard many say. Keep that area clean. Get that sucker clean, because there's areas around the implant where you just can't clean unless you've got, a little bit of help. Do the best you can. These are some numbers that put everything into perspective. Overall success rate of implants is approximately 75 to 97% success in type 1 and type 2 bone over 10 years. So the implants are generally very successful. Overall failure in type 2 or type 3 and type 4 bone is 83%. Now that's because they didn't do a graft, they put it in and they didn't worry about it, they covered it up or they loaded it too soon. These are the implants just going at very low torque values. I guarantee that those are going in type 3 and type 4 bones. They're probably not getting primary stability numbers on their torque. They're probably getting 20, okay, maybe if 20, but they're definitely not getting 35 to 55 is where you want to be, okay? So just know that a high number of these implants are going to fail in that type of bone, and more so in the maxilla, okay, than in the mandible, okay? Failure, 10% of all implants placed by a dentist, this is according to the literature. Thibault, there's two articles I quoted down here for this, Thibault and Coy et al. 10% of all implants placed by a dentist are going to fail. So just plan for that, okay? Don't beat yourself up over it. Do everything you can to prevent it, but just know that for one reason or another, that 10% of your implants are going to fail. And major risk factors include 75% of those major risk factors are bone density problems. 42% are failed sinus lifts or sinus or grafting techniques, 8.3% smoking, 8.3% infection, 8.3% rheumatoid arthritis. So think about that. 25% of implants fail worldwide, of all implants placed. Of every implant ever placed, ultimately fails 25%. Now, this is counting beyond the 10-year mark. So 25% of those are going to, 25% of all implants are going to fail beyond 10 years. But your best bet, if you're putting it in type 1, type 2, and maybe even type 3 bone, you're going to have pretty high numbers as long as you've taken steps to be trained, carefully selected the patient, chose good bone, and the patient takes care. You're going to have general success. So this breaks down a little bit more. You got 97% of single tooth implants are successful. 96% of implant-supported bridges are successful. Bar retained overdentures, hybrids. Okay, those are 94%. Clip. Why are these so high? Because they're mutually supported. So it's not just one implant. We're mutually supporting the implants together. We're dispersing those forces, those lateral forces. Clip retained overdentures, 81%, and tooth supported bridges. Okay, that's 75%, 74% without an implant. So think about these numbers compared to a traditional fixed prognosis. You're doing pretty good with implants as long as you do what you're supposed to do. Key factors for osseointegration. Now we're going to start moving a little bit faster. We're almost through with this implant discussion per se, but we talk about integration. What does osseointegration mean? Okay, it's material. Basically, we're talking about we're not talking about zirconia. We're talking about titanium implants. It's a grade 4 surgical titanium alloy that is attractive. It's bio inert. Okay, for healing. The fixture design makes sure precision fit in vital bone, prevention of heat generation during drilling, healing period, surgical procedure, and implant bed. Make sure there's healthy bone. So as long as you're thinking about these 6 items, you're going to stand a good chance. These are your keys to successful integration, osseointegration. The prime time for implant healing or integration is about 3 to 4 weeks, because now and we're going to show the cascade of effects here in a second of healing, but basically the primary stability of the old bone and the transition to the new bone is happening right at about that 3 to 4 week period. All right, for your healing. But now we want to let these heal. As far as time, we want to let them heal for 3 to 4 months. Generally speaking, we know that according to the literature, is a time that's going to be required for adequate integration. And what does that mean? So primary method of integration of an implant into the bone is called osseointegration. And even though there is considerable literature demonstrating initial mechanical and pressure retention upon the initial placement, osseointegration still has to occur. So what that means is, are implants just merely screws going into a piece of wood? Okay, yes, because the bone expands and it contracts. It's sponge, okay? If you ever experienced putting an implant in, and I've done this, you get it in, you on a cadaver, you place it and you can only get it halfway and you just can't turn it anymore. And you're at 60 Newton centimeters, you're running the risk of stripping out your driver, or say on a small diameter implant with a one piece, you could break that thing off. Well, the bone is contracting around it. They actually expand and contract as you put it in. So what you can do maybe is you can let the bone rest. You can actually turn a quarter turn and let it rest for 10 seconds. Turn another quarter turn and let it rest for another 10 seconds. You can eventually get it in. You can squeeze it in. That's why all the rage now are these densification techniques. A lot of discussion about that at the AID meeting this last week, about using densa drills and things like that to expand the bone and condense it all the time, at the same time as you're creating your osteotomy, densifying the bone, and now you're placing the implant in, and you're giving that a chance to retract and squeeze around the bone. So great technique. A lot of studies being done on it right now, But bone is dynamic. Okay, bone is that trabecular bone is very dynamic. Once you punch through that hard cortical plate, you're into the medullary bone, the cortical bone, the medullary or the trabecular bone, and it's very vascular and it's very, the type 2 bone, it's going to expand, it's going to contract, you'll feel it. Okay. So beyond that, okay, for the single piece implants, for the one piece implants, you rely on that pressure fit. And to a certain extent, you rely on that for initial stability if you're going to load it. Okay, so do I have 35 to 55 Newton centimeters? Can I load that crown now? Well, that's due to the pressure fit. But we know now that with time, very short time, within 3 to 4 weeks, those implants are going to integrate. You're going to have osteoclastic formation, you're going to have osteoclastic, osteoblast formation, you're going to have bone formation into that micro anatomy of the implant now, and it's going to actually adhere. And that's the osseointegration that Dr. Brandemark discovered. He started studying this in 1952, and it was the goal of an implant. It refers to the direct structure of the permanent osseous and functional connection between living bone and the surface of a load-bearing root implant. That's osseointegration, and I'll give you a sneak peek here. That's Dr. Brandemark. You ever see the picture of him? He's actually a Swedish physician who adapted orthopedic surgery and implants to dentistry. And he basically coined the term of osseointegration. He's the father of how implants heal. So I gave you a little sneak peek. The other thing that happens is you actually have fibro integration. Okay, so that's the Weiss theory, which is fibroosseous formation of a new ligament formed between the implant and the bone, which is tantamount. It's very comparable to how the PDL functions in a natural tooth root. It doesn't give proprioception, but it gives that ligamental attachment. It's collagen fibers that are present, and they interface and they act as a perineal implant ligament type structure, and they call it the osteogenic effect. And it helps with the bone formation altogether. So those two types of integration, I've got another slide about those in a second, contribute to stability and when an implant is integrated. Generally 2 to 6 months. It can be immediately loaded if you have primary stability of 35 Newton centimeters, or you use an ISQ number, which is implant stability quotient. I think I do have a picture of that coming up here. I don't want to get too far ahead of myself, but you can get an ISQ number, which is basically a resonant frequency. You have to take the healing screw off, screw in a device, and you actually test the vibration of a resonant frequency going into the implant to decide how much contact of bone is around that implant, which is really cool. It's kind of expensive, but it's still a great way to assess primary stability or overall stability of an implant. It's better, according to the literature, than just torque value, because torque value is just friction resistance of the bone, of the implant in the bone. Okay, it gives you non-integrated numbers. Okay, it's a strength of how well that implant is sticking in the bone. And then there's also numbers that are discussed that are considered BIC, which is bone to implant contact, which is also another standard. All right, so fibroosseous integration, this is the Weiss theory. Fibrous integration is tissue to the implant contact with healthy, dense, collagenous tissue between the implant and the bone occurs. Remember that PDL. It's a new implant version of a PDL. Fibers are arranged irregularly, parallel to the implant body, when forces are applied, they are not transmitted to the fibers. So it kind of protects. And there is no bone modeling expected in fibroosseous integration. In coordination with osseointegration, which is a direct bone interface, which occurs as the implant is allowed to heal undisturbed. And that's the critical part of why I like to see those implants and why I've heard other clinicians say that they prefer to let them heal. Cover them up, let them heal, even more so than a healing abutment. Now, I'm kind of mixed as a technician because I like to have nice emergence profiles. I like to have custom crowns put in, custom temporary crowns, because I want that to be a beautiful emergence profile coming out of the implant platform up through the transgingival space give me a place where I can put a nice crown on. And I promise you, you can make beautiful looking crowns that look just like human teeth coming out of the gingia if you do it this way. Those are healing abutments. But you'd have to take those out of occlusion, because undisturbed means you're going to flap, you lay a flap, you're going to expose the bone, you're going to place a healing screw on it, cover it up, do primary closure, let it heal with a membrane, and come back. Maybe do some bone regeneration at the same time, and with some grafting, and let it heal. 4 to 6 months, you come back, patient's ready to be restored in a good way. They've got nice, good, fresh bone there that can be restored. Main factors affecting osseointegration include implant oxide layer contamination. That's something that can happen if it drops in the ground. Replace it. Don't try to do that. Now, if you had to reverse it because it's too tight, put it in a sterile area. That's fine. Don't be manhandling it with your gloves, but you could actually reinsert it in the mouth during the osteotomy. And poor temperature control during drilling, and we're going to talk about that. Okay, here's a quick idea. Here's a quick look at the cascade of healing, okay, that happens. First, you have a blood clot between the fixture and the bone. So you want to cause healthy bleeding. When you, for example, if you're doing an immediate extraction and you pull that tooth root out, you want to debride it and you want to expose new bone. You want it to bleed, okay, because that blood clot formation is very, very important. If you don't do that and get all that yucky infection out, yucky, that's a very technical term here. You take all that infection out. If you don't do that, it's going to interfere with the healing, okay? So the osteotomy is the same thing, okay? You want to make sure that osteotomy is created in a way that promotes a nice, fresh surface, cut surface to that bone inside the osteotomy. And that can be poorly done by a bad drill or bad speed or the incorrect speed, which we'll talk about. So you want to have good blood clotting. You want to have the procallus formation, the formation of the fibroblasts and the phagocytes. The procallus becomes more dense and becomes connective, and then you have osteoblast addition with the callus tissue, cartilaginous callus, fixture between the bone, and then you have bone callus that penetrates them and matures, and then your final, then you have complete integration. You've got good bone formation that you can now create a prosthetic on top of. So you want to be able to promote these activities, and anytime you interrupt that or disturb it, as it said, you run the risk of the implant failure, because once you disturb this, whether it's mechanically or not preparing it correctly, the implant could be doomed from the beginning. So if you create an osteotomy as a clinician generate too much heat, you could damage the walls of that osteotomy and not allow for this action to happen. The same thing, you could tear up the bone if you use a drill that's not been properly maintained, if it's been used too much, okay? And then there is literature now stating that pressure necrosis as opposed to heat necrosis is not a big a deal, meaning that, before they thought that you could tear up the bone and cause pressure necrosis, they're finding that's quite not the case now, where heat necrosis is a very big problem, where you're generating too much heat. When you're creating these osteotomies, you must use the appropriate speed based on the density of the bone, and use copious amounts of cold, sterile saline. Keep those hydrated and wet and cool when you're making it, and that has to do with your surgical motor. So, a lot of opportunity to damage the bone, but we want to increase the chances of providing the chance for this cascade to take effect. That cascade occurs on a prepared surface. There's additive surfaces, there's reductive surfaces. I'm just going to talk about one surface. This happens to be the Sterngold acid etch surface. It's called SGE. Now, 99% of the companies that make implants, and there's about 260, 80 companies out there now that are making implants, most of them prepare their implants this way. Now, there are surface application processes where they're actually they're anodizing and they're applying plasma surfaces, roughened surfaces to the implants. but most implants are prepared with an acid etch blasted with titanium oxide. They're blasting and they're preparing the surface in a reductive way to cause more surface area. And that's what it looks like. So most of the implants are going to look like this. They may call it something different, but this is what it is in effect. Okay. It's acid etch and blasting. This allows for integration. We want this because we actually knew Dr. Brandenwark found out that a machine surface, a polished surface, would actually integrate too. This allows it a lot faster. Okay. Here's the ISQ, the implant quotient or stability quotient. This is the Ostel unit. Again, it's kind of pricey, but it gives you a resonance frequency based on how stable, how much contact of bone to the implant there is. So it measures the frequency and of the vibration, and it's comparing the resonance frequencies to the amount of contact to that implant. It doesn't really correlate. It doesn't really correlate to torque, just to be clear, because torque again is friction, not stability. So this actually gives you a better idea of how much contact there is. And what's really nice in the latest implant CVCT material, or what am I trying to say here? I can't say the name of the company, but there is technology now, the latest technology for one of the biggest manufacturers in CVCT, the company responsible for making most of the sensors. They've now been able to eliminate scatter, which means that when you, in the old days, just 5 years ago, just a year ago, you do a CVCT and there's an implant or something metal in the mouth, it shines, it flashes, and it distorts everything you're looking at. Now they've been able to eliminate that. Okay, so now you can eliminate scatter, which means you can see an existing implant in the mouth and in the bone, and it gives you actually a rainbow effect of how much bone is contacting that implant and where, and the density and the amount of osteoblast cells that are in that area. It's an amazing thing. So this is all brand new technology. It's coming out now. It'll be coming out in Chicago in March or February. And it's really exciting to see what we can do now. So not only do we have things like ISQ, we can now visually see it in a CBCT in a map, and we can look at that implant in 3D, and then you can spin the implant around and see where the bone is touching that after 4 to 6 months. It's beautiful. It's a beautiful thing to see what you're getting. And it'll it'll give you an ISQ, or it'll give you a Hounsfield reading of the bone in that area. So it'll say, okay, I've got 1,250 Hounsfield units of bone. They're on the buccal surface of that implant. It's extraordinary. It's amazing technology, and it's just getting better. So I would encourage you to go out and look for that. Okay, drilling speeds. Very important that we understand based on what you're doing, the function. Generally speaking, higher density of the bone, the higher the speed needs to be. We're looking somewhere in the neighborhood of 1,000 to 2,000 RPMs. Usually we're in the average of 1,500 RPMs to drill into type 2, type 1, type 2, type 3 bone. Okay. Make sure that it's appropriately irrigated to avoid heat generation, heat necrosis, and that would inhibit your osteoclastic and osteofibrotic growth. Generally speaking, we're talking about for final drills, for straight drills, we're looking at about 1,500 RPMs. Bone taps, we need to slow down, obviously, because we're tapping. Tissue punches around 600. Flat drills for planing the surface to give you a nice plane surface on a ridge is about 650 to 900 RPMs. Crestal bone drills, which are slightly they're like countersink burrs. Or drills. They open up the area in the neighborhood of the crestal bone. So when it's dense and it's thick, the implant will insert easier. And bone mills, that's another subject for another day. But usually if you're around 1,500 RPMs, you're going to be fine. If you drop it down too much, you're going to create heat. And if you've ever drilled on a sawbone or on a cadaver without saline, you pull that drill out and you feel like you're going to burn your finger on that. Just think about that damaging the bone. Okay, so speed is your friend. All right. we've rushed through that. I want to go through guided surgery just for a little bit, a few of the concepts on guided surgery. I want to round it off with our last 20 minutes talking about overdenture implant dentistry, all that we've just discussed as it relates to overdentures, because another workflow that we can apply to your practice with relation to implants. But first, I would promote guided surgery. If you haven't done implants, if you haven't placed implants yet, you're getting into them, because a majority of the great implant placers on the earth today are people that do it freehand. And I'm not going to disparage any of them, because they do a very good job at it. They've learned how to do it. They know how to analyze the bone, and they do a very good job. And a lot of those folks don't like to go guided because it requires a lot more work up front, a lot more time, because you got to plan it. You got to, you got to have the CBCT. You got to, make a guide. But for somebody who's just placing an implant for the first time, this is your kind of an insurance policy, because it eliminates the room for error, and it minimizes your chair time. You acquire the data, you treatment plan it, you design it, you make a guide, you go through the guide, place the implant, and you're done. Okay, you can literally do it with your eyes closed. I say that very figuratively, but that's kind of how you do it. You have freehand technique, which involves CBCT and X-rays. You can do a stent. You have a pilot drill, and you go to the final depth and diameter, and you're done. Partially guided surgery, CBCT planned. Again, I put CBCT in all these. Should be CBCD, but pilot drill, you can you can place the implant manually if you want to, or you can use your surgical motor. Fully guided with keys, which are most of the systems out there now, which means that they're taking existing surgical kits and they're adapting those to do guided surgery. Every diameter drill, we're drilling progressively when we drill an osteotomy. Remember, we want to preserve the bone, so we go small increments in depth and diameter. We don't go right to final depth and diameter, because we will destroy. You're not going to place a 4.5 by 15 millimeter osteotomy with one drill into the bone. You'll ruin the bone. Okay, you have to go gradually. So you'll do a pilot drill, a 2.0. You'll go and expand it to a 2.7, a 3.2, a 4.3, and then you go to the 5. And all the while you're going slightly deeper. There are two different ways to go. Either go to final depth first, so take the pilot drill down to your final depth and then expand that, which is, I would say, a majority of the literature supports that, but just about as much of the literature supports going final diameter and then deep. So either way, we're doing it progressively. And some implant companies will let you jump drills, but if you do a guided surgery plan, they're going to give you a protocol that is based on that implant manufacturer's recommendations, and it's going to tell you, okay, use this drill, this drill, this drill, this drill, this drill. It's going to gradually create that osteotomy in a nice, gradual way, safe way, cool way, to give that perfect osteotomy, create that perfect osteotomy for the patient. Okay. But what they did is, in the old days, 5 years ago, they had keys, and so they'd have a tool. Basically, it was little, we called them spoons, but they were keys that were the diameter of the drills. You'd have to switch out for each one of your guide sleeves in the guide. So another set of hands, kind of laborious. Now we've got what's called fully guided, which is one drill, one hub, one sleeve, and you can just do everything through one sleeve. You don't have to switch it out. So less hands involved. It's a beautiful thing. Okay. All right, so what you're doing is freehand is going, straight into the, creating your osteotomy with final depth to diameter. You've got partially guided, which involves a guide or a stent. You're using a CBCT. You're using guides, sleeves, multiple sleeves. You've got, here are the spoons I was telling you about. You've got different diameter guide sleeves, and then you have fully guided or fully keyless guided surgery, which is one sleeve, one drill that allows you to, and I'm going to show you an example of that here in a second. So what are the advantages of guided surgery? Pre-plan, avoid anatomical complications, reduce risk of error, prosthetically drive your case, prosthetically design, because you can bring in the prosthetic into your design, reduce the requirements for grafting because you're strategically placing the implant in good bone, place the implant more precisely, facilitate multiple implant placement. You can go flapless a lot of times if you want to, because you can use a tissue punch. Less complex procedure, immediate patients. You can fully plan the procedure. You can extract the teeth digitally, extract the tooth, place the tooth immediately in the socket. Improve overall success and final prosthetic outcome. More efficient procedure, less chair time, reduce appointments. Coordinate restorative phase into the plan. Build your practice, increase referrals. Overall benefits using CBCT, get the anatomy, the bone quality, and you got some liability coverage because now you're doing it with complete care, okay, so to speak. And that's not to say that the freehanders don't do it that way, but this way you've covered all your bases and done it as carefully as you can, okay? Disadvantages, the cost. You have the CBCT machine, you've got the guides, new kits. You can make the guides in office. There's a learning curve with guided surgery, upfront time instead of efficient appointments, but you can minimize the number of appointments. And a lot of times you have vertical opening issues with all the parts in there. So there are certain situations where you can't get the patient open wide enough to get all the guide and the drill and everything in there. Data acquisition, the plan, you drill and you create a guide. Generally speaking, we're talking about data acquisition through scanning. You scan your prosthetic, or in the immediate case, if you're going to pull teeth, then you bring it into the CBCT and you plan it. Okay, you place the implant precisely where you want to. You can see it in all the slices. There are multiple companies out here that provide great implant planning programs. You've got RealGuide and Blue Sky Bio, which are kind of standalone softwares, and you have others. exocad and 3Shape, those are a little more expensive options because you have to already own 3Shape or exocad to get the modules, and it can cost 15 to 20,000 bucks to get everything you need to plan a case. Where RealGuide and Blue Sky, you can design the case for free and just pay for the export file for the guide, which is a really good thing. And you can pay for services to help you design it as well. You have a standardized guided surgery kit. You have your guide. You have tooth-borne guides for single implants. You've got, that look like this, they go on like a splint. You've got tissue-borne with fixation screws or pins, and you can do full flaps and anchor to the bone. These are more accurate, a lot of times used for full mouth reconstruction. But guide sleeves for the keyless look like this. You've got one drill that's got a hub on it that goes through one sleeve, and all of your drills they look like this. So even though the bottom part, the drilling part, is different, the hub that goes through the one sleeve is the same, and it's got a vertical stop on it as well. So wherever you place that implant in the design, it's going to calculate where the sleeve needs to be, and this drill is going to drop in right to the right position and right depth. So all you got to do is go 1, 2, 3, 4, 5, and you're done. Okay, it's really nice. Just like I show here, okay? Gradual. All right, let's finish up with overdentures for about 10 minutes. I want to go through this. We understand that the problem with denture patients are that the denture doesn't stay in the mouth. We need to figure out a way to provide them a way to secure their denture, to have them, give them the quality of life that they deserve. How can we do this? With an implant, some type of overdenture attachment. And the fact is that denture patients are generally psychologically affected by the fact that they have dentures. They're ashamed of it. They're uncomfortable. Poor aesthetic fit based on how the denture is made. Poor retention, accelerated bone loss because of that retention, loss of vertical because of the denture and the bone loss. And we talked about how the bone resorbs. Okay, and you have phonetic changes. Facts are that 41 million patients in the U.S. alone exist, 15%, that are edentulous, that need some type of edentulous treatment, okay? 10,000 baby boomers a day are coming on board that fulfill that requirement. 90% of people are unhappy with their dentures for one reason or another. 90%. Of those people, 63% are unhappy or keep it secret. 32% of those people keep it secret from their friends. 10% keep it from their siblings. And according to the literature, to all these sources, 7% keep it secret from their spouse or partner. Imagine that. Okay, that's how embarrassing and shameful people are about dentures. So we got to fix them. We got to figure out a way to improve their quality of life so they're not so ashamed. Okay, lifestyle changes, inability to process food efficiently. They can't eat or chew. They can't eat their nuts. They can't taste. They can't eat their steak. Overall quality of life drops dramatically. 80% of their diet changes. They can't eat corn on the cob, nuts, apples, steaks. Maintaining the denture is a pain in the rear end. I'm going to go past this video. So the advantages of creating an overdenture situation, you get less bone resorption now because we're stimulating the bone. We get stabilization because now, remember, this is implant retained, not supported. So the implants are keeping it in place. The tissue is supporting the occlusal forces, so it's better on the implants now. Even the supported over the mucosa is very important. Maintain occlusion, eating efficiency, bring back normal food to their diet. That is important. Improve aesthetics. You can get rid of the palate on a maxillary overdenture. You let them taste again. Get them back to 20% of their normal function to over 75% of up to 60% of normal biting forces restored. And you can give them normal chewing efficiency. Why wouldn't you want to do this for your patient? Okay. Restore confidence, quality of life, and affordable. It's a more affordable option generally than a fixed option. Okay. And then you have root-borne attachments, which are really important because those are, for example, I keep saying in the olden days, when I started my career, we were still doing custom posts on top of canines. So we keep canines in the lower and place an overdenture over those because you're preserving the bone because you're leaving the roots and the root tips, so the roots in the mandible or in the anterior mandible, but also you maintain proprioception. So now the patient has some type of proprioception where they know where the denture is in space and where they can actually chew better. So the standard of care really, according to the McGill and the McGill study that came out of Canada and the British consensus, the standard of care should be an overdenture with 2 implants in the mandibular arch. In other words, if you've got a lower denture patient, they shouldn't walk out of your office without 2 implants at least of conventional implants or 4 small diameter implants to hold that denture in. That's very, very important. All right. Fact is, well, that's the British Society. This is the report I just I cited. You know, they basically say that we have to take care of our implant patients. So what is an overdenture? It's an implant or a root form plus an attachment equals security. All right. Disadvantages, yeah, we're back to that space thing. We need a lot of space. They could be bulky because of that. They reduce strength because of the bulkiness. They go thin. And the relative cost. If you start adding in bars, they get kind of pricey. But you have all these different options for overdentures, most of which include implants. All right. You have hater bars on bar. You have bars on implants. You've got individual locators. These all include implants. So it's important that we choose the right system for our overdenture. And so that includes the correct patient selection, making sure, again, that it's prosthetically driven, understand our attachment options, understand the restorative space available, what the opposing arch is, and the number of implants, the arrangement, and finally, well, does this remind you of anything we've been talking about? All these principles still apply for the regular implant principles. Patient selection is very important for obvious reasons. We talked about it before. If we don't, we could be failing before we even start if the patient's not carefully selected. Prosthetically driven, we've talked about this. We got to make sure now that we understand those denture principles so we can prosthetically design the case on top of the implants and promote the most success we can. That way we understand the restorative space we need. We have resilient attachments and we have non-resilient attachments. So we have things called resilient attachments like the ERA, for example. This is a Sterngold product. This was the first resilient overdenture attachment, which recreated the natural amount of resiliency in the human mucosa. It was determined in 1956 that 0.4 millimeters, 0.4 tenths of a millimeter, or 4 tenths of a millimeter of resilient bounce existed in human mucosa. So Sterngold came out and created the ERA, which allowed for an attachment to be made that allowed for that cushion to allow the denture to rest on the mucosa, yet staying retained. Okay. Then you have non-resilient like bars, like hater bars. Those rotate from the anterior and again rotate back onto the gums, onto the mucosa. The ERA comes in different styles with different amounts of retention. There's a family of attachments, just like we have the locator. You can go into roots. You can go into implants, or you can go angle correction. And I'm going to talk about angle correction in a second. And I apologize because we're rushing here to get through this. But the Stern Snap is also a Stern Gold product. It's very similar to the locator, which involves a 3.8 stud attachment, which is standard across the board now, which has a polyurethane cap. Very good option. Okay. Zest Locator, something everybody's familiar with, probably the #1 name in overdenture attachments. It's become kind of the Kleenex name of attachments because it's very widely used, is very successful, and people know how it works. But they offer implants, they offer, they offer implant abutments, and they were the first company to offer angle correction. So the ERA that I showed you earlier was made, but it had to be parallel to function with the resiliency. Zest came out with an option where now you can go to 10 to 20 degrees and have some type of angle correction and still have some form of retention, which is great. And they've added all these different levels of retention. So now we can go angle correction, but just remember, with greater angle correction, it's inversely proportional with the amount of retention you have. So if you're at a greater angle and you're trying to correct for angles that are misplaced in the mouth, because all bone is where it is, and you're going to have to place the implants where you have to place them, the more angle, the less retention. So that's why they have so many different options for increased retention on these abutments. All right. And keep that in mind. So here we have Zest Locator implants. You can put them into bars. Great option. Another great thing they have is the the Locator Fix now, where they've changed these from nylon, their inserts, to PEEK. Now it snaps on as hard as a fixed, and you can, in all intents and purposes, have a fixed restoration now. Very cool for mutually. Now we're back to supporting your implants or your prosthetic, but now they're in the mouth, they're mutually supporting, and along with good mucosa support, you're going to have a very good restorative option. And this is a little more expensive, but very cool option. But the only difference in this in these different systems is, as I mentioned, you've got Stern Snap, you have the Zest Locator, you have the Novalock, which is also 3.8. You've got the Overdenture by ZimV. They all function the same. Okay, they're all the same size, and people are going to tell you that no, you have to use our caps on our implant. Well, I can tell you that these are all produced after the same OEM 3.8 millimeter size dimension, because the locator IP ran out and everybody uses the same ones. So again, they're all resilient in their own way. They have a little bit of a vertical bounce, but well, to get to me one more thing. You also have the option, before I get to the butt, you have the O-ball option. So you have the option to use an O-ball. O-balls are very, very popular. Gordon Christensen votes this #1 go-to attachment other than locator because they're very versatile. Okay, and there's a couple of different ways to have an O-ball. You can either have that through a small diameter implant, which is single piece, or you can have it as an abutment, which is the ORA, which goes on to 150 different implant systems, where you can have a ball attachment now and have an overdenture. These are very versatile because you get full retention at about 15 degrees angle correction. ORAs are very, very versatile. They're very user-friendly, okay? And then you have the root anchors that we mentioned before. They go on to roots. You allow proprioception and ridge preservation. Look how that ridge is maintained. No resorption at all. It's beautiful. Hater bars, very stiff, very rigid options, but I like these because now you're mutually supporting over multiple implants. So it's a good thing. I like bars. We like bars because you get mutual support. You're protecting all those lateral forces on the implant. But you need room. You need a lot of room for those. How much room do I need? Well, we talked about that before. Make sure you understand how much room you need, whether it's doing a digital design or working it up with your lab tech. Understand the space you need. Understand, remember, if we saw this graphic here, we're going to measure from the apex of the ridge to the incisal edge, and you're going to need a lot of room for bars. But at the end of the day, you're going to need 9 to 12 millimeters for some type of overdenture attachment. You're going to need 8 to 12 millimeters for a regular implant, remember. Bars, you're going to need 13 to 20. Remember, we need more space. If you have that space and you have the option, the ability to do it, then by all means, go for it. But you might also want to include a framework in your prosthetic to give it a little more strength, because a lot of times with a reduced space, you have less acrylic, so you need more strength. I love frameworks in these. You get meshes or printed frameworks. Definitely go for that inside your overdentures. So to be safe, 10 to 15 for individual attachments, 15 to 20 for bars or multiple attachments. Understand what your opposing arch is. Remember the occlusal forces. Is it natural teeth? Is it a zirconia bridge? We like acrylic on acrylic. Understand the occlusal forces. Go back and get your denture, brush up on your denture techniques. Understand your function, your form and function with denture occlusion. Number of implants. The implant strategy du jour for overdentures is 2 on the lower and maybe 4 on the upper. This is kind of according to the literature, which I brushed over really quickly. These articles here support how to use 2 on the mandible and 3 or 4 on the maxilla for an overdenture situation. This is your ultimate implant strategy. You could do this, I guess, with 1. It's better than nothing, but you got to be careful on your strategy, because it could be excessive, it could be inappropriate. All right. And finally, I want to talk about angle correction. We did talk about angle correction. Implants are going to go where the bone is, and so for overdentures, we want to be parallel. Think parallel when you're doing overdentures. Locators allow for angle correction. ERAs have physical correction, which is nice. It brings you back to parallel. O-balls allow for about 15 degrees. You can get about 20 degrees out of a locator type. But now some companies are coming out with fixed angle degrees, so you can try to get physical angle correction. And for example, the Straumann Novalock has 15-degree fixed corrections. Remember, the ERA had multiple choices. The Zimmer has a 0, 18, and 30-degree correction, for their overdenture system, which is great because we want to be parallel. We want to be parallel to get maximum retention, least amount of wear. But the Stern product has an angled. So now this is a variable angled. This actually has a multiple part here where you can adjust it up to 17 degrees. So you have 15 degrees inside the cap, 17 degrees on the angle correction, and you get about 62 degrees or 32 degrees per implant. And between 2, you could have up to 62. And this goes in looking like that, where you've got 2 parallel abutments, where you started like this. You can end up something like this, something close to parallel, and you can have a great parallel retentive overdenture. And finally, digital overdentures is something that's coming on very strong now with a lot of the softwares, exocad 3Shape. You can order digital spacers, scan your spacers on your abutments, and scan those into your software, create your denture, your overdenture digitally, where you don't have to sit there chair side and hog it out. And it's a beautiful, beautiful opportunity to create a very effective prosthetic. And then finally, bars. I love bars, but again, you need room. They can be very expensive. A lot of really cool options. Very stable, mutually supportive over the implants, protecting the implants, and consider that. Okay, we're done. I know we went a little bit long, but we were worried we were going to be too short at the beginning of this today. But with that, I'd like to thank you for your time. If you have any questions, we have a few minutes to answer questions. If not, I thank you for being with us in NDX tonight. My contact information is here if you need to contact me for anything, any questions. Gene Peterson at sterngold.com. I'd be glad to contact you. You can email me. I'll call you on the phone, whatever you need to do. But thanks for your time tonight, and look forward to seeing you again.